Dr. Jason Bacha from Baylor College of Medicine Children's Foundation, Tanzania, reporting on the DTGs of DTG for children and adolescents living with HIV, or CALHIV, descriptions, trends, and gaps of rolling out Doletegravir in CALHIV in Mbeya, Tanzania.
Hello, ladies and gentlemen, and friends and colleagues. My name is Jason Bacha from the Baylor College of Medicine Children's Foundation, Tanzania, and the Baylor International Pediatric AIDS Initiative. And I'm excited to present the findings from our study titled The DTGs of DTG for Children and Adolescents Living with HIV. Descriptions, trends, and gaps of rolling out Doletegravir in children and adolescents living with HIV in Mbeya, Tanzania. The background to the study, as I think we well know, efficacy and safety data of novel ARVs in children often lag behind the adult data, and this lag can lead to hesitation and slow uptake by prescribers of using new ARVs. Regarding DTG specifically, some of the early trial data has been reassuring in children, specifically the IMPACT and Odyssey, but of course it's small sample size and hard to know how it will translate to real-world settings where the medicine is used and needed the most. In 2019, Tanzania procured DTG, updated guidelines, and began a country-wide rollout. And therefore, to try to understand better the use, the safety, and efficacy of DTG in Tanzania, we studied and described the characteristics and outcomes of this rollout in children and adolescents living with HIV treated with DTG in our clinic in Mbeya, Tanzania. The methodology we used, we did a retrospective chart review to describe these characteristics and outcomes of children who were prescribed and given DTG as part of their ARV regimen. The site, again, was the Baylor College of Medicine Children's Foundation Tanzania Center of Excellence in Mbeya, Tanzania, which is in southwestern Tanzania. The inclusion criteria of our cohort was children and adolescents ages 0 to 19, HIV positive, who are on ART and in care at the Baylor Tanzania Clinic in Mbeya. And the dates of analysis were through the 1st of March 2019, when DTG became available at our site, through the end of that year, 31st December 2019. Also of note, we defined HIV viral load suppression as less than 1,000 copies per the WHO in-country guidelines. What did the results of our study show? We had 681 patients who received DTG at the Mbeya COE during the time of study in 2019. The 681 made up 46% of all patients on ART at our center and 60% of patients who are eligible to receive DTG, defined as having a weight of 20 kilograms or more. The pie figure below shows the distribution of regimens used. You can see the majority of patients receive the TLD fixed dose combination. The table on the right shows the baseline characteristics of our cohort. There was a nice split of male-female. The average age was right around 14 years of age, ranging from 5 up to 19. The time on ART was average of 5 years, again ranging from new initiations up to 14 years of ARV exposure. Baseline WHO stages of the cohort showed over 60% with a stage 3 or 4, reflecting the complex care and complex patients we see at our center. But thankfully, through the course of the study, 98% of patients were able to be at WHO treatment stage 1. Also of note, we had about 60% of our patients with some form of severe or moderate malnutrition, again reflecting the complexity of patients in care at our center. And as for the ART status of this cohort, 12% were new ART patients with new initiations. The remainder were shifted from prior regimens, with the majority, 62%, that had been on NNRTI regimens. As for our outcomes data, we had very reassuring data with 0 patients having any severe drug toxicity or negative outcomes. Of the patients on DTG, 95% of the cohort remained actively and safely in our care, while the remaining 5% were successfully transferred out, and we had 0 deaths and 0 loss to follow-up. Also, of our DTG cohort, 77% were able to utilize multi-month prescribing. The figures on the right, the upper figure shows viral suppression rates pre and post DTG amongst our cohort with viral load results. Prior to the DTG, 77% were virally suppressed, and at the end of the study, post changing to DTG regimens, 84% were virally suppressed. The bottom two figures, on the left it shows of patients with viral loads pre and post who were initially unsuppressed. We were able to suppress 63% of those patients by using a DTG regimen. Likewise, of patients previously suppressed who were changed to DTG, 95% were then suppressed through using DTG. So in summary, our study showed that DTG was very well tolerated and quite effective in our clinically diverse cohort of adolescents and children living with HIV. Again, there was no toxicity, no adverse events, no deaths, no issues with DTG. It also showed that the use of DTG resulted in viral suppression for many of our previously unsuppressed patients. And these results, we hope, are very encouraging, and that they show that DTG can successfully and should successfully be used in children and adolescents living with HIV. Thank you very much for your time and listening to this presentation.